Hi, my name is Lona Muthania Ochido, and I'm making it one of my life's mission to demystify the speech therapy field and to empower more parents on what they can start to do in order to optimize their child's communication outcomes. So whether you want your child to talk more or talk better, learn better, and overall optimize their potential. So stay tuned and feel free to send in any topics on speech and language development you'd like for me to tackle. Today's What Is series, I am tackling what is occupational therapy, or who is an occupational therapist, or does my child need to see an occupational therapist? Now, on these questions I get a lot. Who is an occupational therapist? Occupational therapists are another group of allied health professionals, just like speech therapists, but their job is quite different from that of speech therapists. Occupational therapists assist children as well as adults to participate in activities of everyday living, ADLs, every activities of daily living, such as walking, eating, dressing, making friends or social skills in children, writing, cooking, driving after you've had a stroke, showering, for adults, etc. So independent skills. Occupational therapists or OTs help people engage in the occupations they want to or need to or are expected to, work reasons, by improving their skills or by modifying the occupation or the environment. So for example, an occupational therapist may recommend that a client with cerebral palsy, for example, starts using a modified walker, a modified cup to increase a child's independence in feeding themselves or drinking, or recommending holding frames that are installed in the bathroom for an adult who has had a stroke or maybe is experiencing weakness and frequent falls. Similarly, occupational therapists may suggest the installation of ramps post-health conditions, like stroke and degenerative conditions. The primary goal of OTs is to help people participate in the occupations of everyday living. Occupational therapists also engage in ongoing assessments to understand what occupations are important to the child or the adult and any issues they may be having in completing these activities, or understanding your goals as a parent or a caregiver. OTs also help people to live with or manage long-term or chronic health conditions such as diabetes, cancer, arthritis, sickle cell, cerebral palsy, etc. OTs help make everyday living easier by either empowering their clients with knowledge and skills or helping them find new ways of doing the activities or changing their client's environment to suit their clients' new needs. Occupational therapists can also prescribe, if they see fit, devices and therapy equipment to help you complete specific or help your child complete specific activities. The scope of practice for occupational therapies, as you can see, is wide, but it does vary with geographic location. In most of the developed countries such as Australia, UK, US, OTs working with babies and preschoolers predominantly work with babies who have developmental delays, not holding their neck up, not sitting. That's the same in Kenya as well. Or toddlers delayed in walking, children with motor planning or sensory difficulties. These could be children who don't tolerate different textures of food. They have really heightened sensitivities to food or texture, or to being brushed their hair or their teeth, children who cannot stand their nails being clipped, who may not like physical contact of any sort, children who display hypersensitivities to sound, etc. The list is definitely really long. Children with attention difficulties, which prevent them from concentrating for longer than short bursts of time, or from participating or socializing with other children. With school-age children, OTs may work to improve handwriting, pencil grip, so this way not an awkward one, and overall fine motor or hand-eye coordination. It's the occupational therapist's job to help children presenting with developmental delays or multiple disabilities or specific sensory processing disorders achieve their developmental milestones and eventually achieve independent completion of whichever activity they're struggling with or have struggled with. So for children presenting with behavioral issues, occupational therapists help the child to maintain positive behavior, e.g. they stop hitting or learn how to positively deal with anger or develop appropriate social skills, etc. For adults, occupational therapists are involved with the client's rehabilitation journey and return to independence post a health condition. This may be through helping people regain or enhance participation to match their pre-health condition status. If they are driving, after the condition, we're trying to help them to get back to driving. The health condition may be hip replacement or spinal injury or a stroke. There are many. Parkinson's disease. Assessing and modifying clients' homes to improve their safety and independence is also something occupational therapists do, as well as prescribing and educating clients as well as caregivers in the use of adaptive equipment to assist in participation. They also provide splinters after hand or upper limb injuries. But clearly in Kenya, the scope of practice of occupational therapists may be slimmer than what I have talked about. And to be honest, I am not sure why. One reason, like in the case of making ergonomic assessments and recommendations of such things as ramps or sitting, chairs, whatever for people with disability, will be something families here may have just decided by themselves without needing an occupational therapist to assess or prescribe. And in developed countries, for example, this assessment by an OT would usually result in the government covering that cost of the ramp, whereas here in Kenya, this cost will be covered by the family of the patient regardless. So that could be the reason why occupational therapists don't need to do those kind of assessments. I recall when I worked in rehab setting in New Zealand many years ago, which is a hospital that admits adults post-stroke. So the post-discharge from acute ward, they would usually be admitted into a rehab hospital for, say, a few weeks and receive intensive occupational therapy, speech therapy, physiotherapy, etc., all under one roof and without leaving the facility. I used to see occupational therapists helping the adults learn how to sequence steps required to, say, tie their shoelaces, wipe their bottoms, or make a cup of tea whilst remaining safe. But here, I don't see occupational therapists involved with this kind of work, at least not the ones I've encountered. I don't see too many occupational therapists who assist children with their pencil grip or improving their handwriting or even toilet training. And maybe it could be the setup. We don't have very many community-based occupational therapists in hospitals. And yes, it may be a matter of what the government here funds for, but I also think it is a matter of the training curriculum that occupational therapists in Kenya, for example, receive, which may not include as wide a scope as in developed countries. That said, my response to any parent that asks me whether their child should drop OT for speech is always the same. This is what I say to them. Ask your child's occupational therapist to discuss what they are working on. So the goals based on the assessment they conducted, and then decide whether these are in line with the goals that you as a parent have for your own child. And if they are, then great. If they are not, then it's probably a good time to request a readjustment or goal setting, or seek another opinion or request to be discharged, really. A misconception that I have noted, particularly here in Kenya, is the idea that a child cannot have both occupational therapy and speech therapy at the same time. So for instance, a child who isn't walking cannot possibly do speech therapy while at the same time attending occupational therapy. Anyway, there you have it. I hope this series helps clarify the role of occupational therapists, and hopefully you can now be better placed to make decisions about whether or not your child requires occupational therapy and whether your provider is best suited to provide those services to your child. Thank you so much for tuning in, and as always, do check out our other series if this particular topic has raised something new for you. Thank you.